have time for two more questions. I wanted to blend two questions in for Julia. One is, while we wait for more data, what do we actually do with post-op patients when patients have a bit of tumor shrinkage, but mostly residual viable disease after chemoimmunotherapy? Would it be more of the same treatment if that didn't work that well before surgery? And adding on to that, it's the pre-op versus post-op. If we can't deliver post-op therapy in numbers that we hope to, is it better to do it pre-op because we'll have better delivery?
Yeah, those are two great questions. I think ones that we all think about as well. Pre-op versus post-op, it's been repeatedly shown in clinical trials and other data sets that we are more likely to successfully give the full course of therapy if it's given pre-op, and means that we're more likely to get patients all those doses of chemo and immunotherapy we planned for. With post-op treatments, people have just gone through a big surgery. You're trying to recover, you're trying to return to your normal life, and it's hard to think about doing another 3 months worth of chemotherapy after you've recovered from your surgery. And sometimes people have complications from surgery that take longer to recover from than you want. And that can also delay or prevent you from getting things like chemotherapy or immunotherapy. So upfront, doing it up front seems to allow us to get it to people more effectively. That's one advantage of preoperative treatment. I think both an advantage and a challenge of preoperative treatment right now is that surgical sample. When you look at what fraction of tumor cells have died, and we'll usually give you a percent viable tumor left. Under 10% is good, 0% is best. But most people will have, so 2/3 of people will still have some, 3/4 of people will still have some viable tumor remaining. And right now, we don't have a great tool available to change that outcome. I want to see clinical trials, maybe we can add something new. Any treatment we add, of course, adds risk of toxicity. So in my own practice, I'm not adding additional treatment, but I am watching closely and hope to have additional options in the future. I'd like to highlight, even if your tumor shows a lot of residual tumor left, you've still had, in most cases, you've still had a complete surgical resection. You still can be cured by the intervention you've already had. It's just we're going to be watching closely.